TopMedTalk.
Hello, and welcome to TopMedTalk here at Anesthesiology 2024 in Philadelphia, Pennsylvania. It is the annual meeting of the American Society of Anesthesiologists. I'm Desiree Chappell. I'm your host, and I'm joined by my co-host, Professor Mike Grocott. It's been a great meeting so far.
It's been fantastic, and looking forward to another really cool interview.
Yeah, absolutely. If you don't know about TopMedTalk is a leading perioperative medicine podcast. We're on all of your favorite podcatchers and platforms, but we have great in-depth discussions with key opinion leaders, presenters at meetings just like anesthesiology, and really able to dive deep into some topics that are very important and hot topics in anesthesia. And today, our conversation is no different. We have the privilege to sit down with Dr. Kurt Ruetzler, joining us to talk about laryngoscopy. Kurt, thank you so much for joining us.
Thank you very much for having me. Excited to be here.
Yeah, absolutely. Now, for our listeners, why don't you tell us a little bit more about yourself?
Yeah, my name is Kurt Ruetzler. I'm an anesthesiologist by training. As you hear, I'm not a native speaker.
No, you're not from here.
No, I definitely not. I'm originally from Austria. I trained in Austria at the University of Vienna, initially cardiothoracic anesthesia. Once I was done with residency, I moved on and joined the clinic in Zurich, Switzerland, and I was there for 3 years. And in 2015, I decided to come to the States for 1 year, maybe a second year, mostly to do some research.
And the rest is history.
The rest is history, yeah. I'm still here, yeah. I currently practice at the Cleveland Clinic, physician scientist, so that means I am 75% in the OR. I'm really providing anesthesia, so it's really affecting myself, what I'm talking about, what my research is on. So it's really how I practice and my colleagues are practicing. Yeah, and about 25% I do research and mostly focusing on airway management and outcomes research. Everything we do in the operating room, does it affect outcomes of our surgical patients afterwards?
Yeah, as a fellow quality person and ensuring that we're providing, high quality care for our patients, I really appreciate that. Tell us about your passion for video laryngoscopy and utilizing this technology and piece of equipment that's been around now for a little while, but really making it into many ORs across the world, really.
Yeah. Absolutely. Let's start with the basics. I think airway management and especially endotracheal intubation is a cornerstone of perioperative medicine. So we know every hour of our surgical patients need an airway, if it's a laryngeal mask or it's an endotracheal tube. So it's so important and critically important to know what you're doing. Generally, I think a lot of clinicians say, oh yeah, it's straightforward, nothing happens, it's always easy, nothing happens, no problems with the patients. But the problem is they are wrong. It's wrong. It's just a wrong assumption. Yeah. Unfortunately, nowadays we know that a lot of patients suffer from injuries, but also significant morbidity and sometimes even mortality just because of airway management. And there's just a recent report from UK, the NAP7 report. Please don't quote me in the number, but it's something like that. 6 or 7% of all patients having advanced airway management with endotracheal intubation have one or more complications. And airway management is one of the leading causes of perioperative death in the operating room. So we are far away from saying, oh, it's straightforward, easy, nothing happens, and we know what we are doing. Unfortunately, this is not true.
Yeah.
So my passion about video laryngoscopy, it started many, many years ago. So as a young resident, airway management, one of the cornerstones, what we are doing every day. And I quickly realized it's not always easy. So are there different techniques? And video laryngoscopes are around, I would say, about 20, 25 years. It's not a really new technique, but at that time, it was a promising technique. And I had the huge opportunity to get involved really early, so 10, 15 years ago, where we had not really good devices, but they were okay, maybe not as good as direct laryngoscopy, which is still considered the golden standard. But yeah, it was a success story over the time. Video laryngoscopes, the devices got better, our experience got better. And I think nowadays, video laryngoscopy should be the gold standard. And one of the large trials we just published clearly advocating for that. Video laryngoscopy is superior over direct laryngoscopy.
Yeah.
So when you say gold standard, do you mean it's the best, which I suspect people wouldn't argue with, or it should be standard of care, which is a rather different question? Should it be what we go in with first?
Absolutely. So it should be the default technique. So every single intubation in the operating room should be intubated with the video laryngoscopy. And there's one important thing, and even as a physician scientist, it's really disappointing to me. We are always talking about the expected difficulty intubation. The problem is we are not really good at it.
Yeah.
We just don't know. Yeah, there are patients here obviously difficult to intubate, and you look at him and say, oh gosh, this will be difficult. But the problem is the unexpected difficulty intubation. Say, oh, straightforward, easy peasy, and it turns out to be a disaster. So having this said, video laryngoscopy is established technique for expected difficulty intubation, but I advocate do it for every single patient, because for unexpected difficulty intubation, you already have the device which is now proven to be superior. So just go with it.
Yeah.
Just having listened to this debate over a number of years, possibly the principal critique is that we're robbing the youngsters coming through of the ability to learn the non-video and so standard old-fashioned direct laryngoscopy. Is there any evidence that that's causing a problem?
So this is not really a surprise that you actually asked me about it, and I hear that all the time. May I ask you, are you riding a horse?
No.
No. Are you riding, do you have a car?
Yes.
Do you drive by car? Why are you driving a car? You can ride a horse.
I can.
Yeah, you can, right? And the same is with direct laryngoscopy. Yeah, you can do it, but it's an old technique. It's a technique which is now proven to be inferior over video laryngoscopy. And now coming back, every one of us, we're driving cars because it's convenient, it's superior, it's quicker, it's safer. So this is the same with video laryngoscopy. Video laryngoscopy is superior. And in the term what you said, we are robbing the technology of our youngsters. I disagree. I just disagree. I had the opportunity to get into residency about 20 years ago, and we did the ultrasound for central line placement. And it's called the landmark technique, where you think there are some landmarks and you poke in the neck of the patient. It's called landmark technique, but this is not true. It's a blind technique. You just poke, and once you have blood, okay, most of the time you're in the field.
Right.
But how you use the ultrasound? You use the ultrasound. It's superior.
I love the power of the anecdote, but we have a physician scientist with us. Tell us a little bit about the evidence.
Yeah. So evidence now, I think we have to, of what kind of evidence we are talking about. And the strongest evidence we have are prospective large randomized control trials. This is also the obvious reason why I'm here. I did one of the largest airway trials. And it's one out of several large airway trials. And just summarizing a little bit we did. I strongly believe what really matters in the operating room is the individual patient.
Yes.
So you have to focus on outcomes that really matters. And I strongly believe what really matters is the number of intubation attempts, the fraction of patients you can intubate with one single intubation attempt. But there are also outcomes like airway injuries, dental injuries, or airway injuries. And last but not least, if you have a device and you fail, you can't intubate this patient with whatever device you have. So I think these are the outcomes which are the most important ones. And in the past, we were focusing on time to intubations or visualization, but these are not the important outcomes. So what we did, large trial, we enrolled more than 8,000 patients, and we randomly assigned patients to video laryngoscopy versus direct laryngoscopy. And we were now looking into the clinically important outcome. And the primary outcome was the number of intubation attempts, or the fraction or rate of patients intubated with one single intubation attempt. And the difference was huge. So we were able to intubate 98.3%, so 98 out of 100 patients with one single intubation attempt using the hyperangulated video laryngoscopy, compared to only 92% with direct laryngoscopy.
Oh.
So we have multiple intubation attempts in 8% of all surgical patients. Now you could say, oh, this number is really high. No, it's not high. So there are multiple studies out there, retrospective analysis that, this is true. This is the real fraction of patients where we actually fail. So primary outcome. Secondary outcome, as I said, really important, failure rate. And failure rate defined as you start the intubation process with whatever device you have, and you try to intubate and you fail. And fail, you as a clinician said, I'm sorry, I cannot intubate the patient with the device I have. And this is a really important outcome. If you use direct laryngoscopy as your first default technique, you will fail in 4% of all patients. 4% of the patients, you need an additional device, any alternative device you might or might not have in your OR, compared to only 0.23% for video laryngoscopy. So out of a huge cohort of 4,000 patients, only 0.2% of patients, you needed a second alternate device. That really makes a difference. That really, really, really makes a difference. And in terms of airway injuries, dental injuries, but also injuries to the airways per se, absolutely no difference. There's absolutely no difference. Video laryngoscopies are safe. It's safe to do it. Is as safe as direct laryngoscopy. one important thing is, as always in medicine, there will never be 100%.
Yeah.
You will never have 100% success rate. You will never have, I have never ever any problems. It will never happen.
Yeah.
So our idea is you have to reduce the negative outcome as much as you can. And I think at this point, the evidence is clear. And we are the largest trial. We enrolled 8,000 patients, but this is one of many trials. So there are at least 5 large trials in separate populations coming more or less with the same result. Video laryngoscopy is superior.
I am convinced. I use video laryngoscopy.
Yeah.
What was the technique? Did you advise a particular technique? So a lot of people, for example, always use a bougie with a video laryngoscopy. Some people don't. Was part of the trial a specified technique, or was you do whatever you wanted?
Yeah.
And let me add it, like a stylet, a specific stylet that is specific to whichever video laryngoscopy you're using, or just in general.
Yeah, this is a really important question. Then as a trialist, I strongly believe in pragmatic trials, because you have to understand, if you organize everything as perfect as you can, this is not the real world experience. It's not how it works.
Yeah.
Right? So a pragmatic trial really shows how the real work really works. And for our specific trial, and I think this is one of the major trials, it was a truly pragmatic trial. The only thing we said, if the patient is assigned to direct laryngoscopy, the first default technique for the initial intubation attempt is direct laryngoscopy. If you fail, or if you have any consideration, you can always switch, but the first one is with DL versus video laryngoscopy. But we again said, you can do whatever you want. Only the first intubation attempt is with the video laryngoscopy. And the only thing what we actually required for the video laryngoscopy, as we were using the hyperangulated one, we required to use a stylet. Because if you use a hyperangulated one without the stylet, most likely you will fail. But for the DL, we said, it's your choice. You do whatever you think you want to do. Interestingly, 98% of our providers use stylet for direct laryngoscopy. Apparently, this is now what we are doing in our institution.
Yeah, I think many are. So speaking of pragmatic trials and then translating the evidence into real world practice, what's that transition been like in the clinic where you work in the OR? Is everybody using video laryngoscopy now?
So I think it's also important, if you talk about the pragmatic aspect, who are you actually enrolling in your study or in your trial? Because the general rule is whatever you find only is reliable in this sort of patients. So we had a real pragmatic trial. We enrolled everyone.
Yeah.
Importantly, it was emergency versus elective cases. We enrolled, it didn't matter which BMI, there was no cutoff. We enrolled everyone assigned to the operating, including patients with a history of difficult intubations. So these are the patients, you and I, and everyone is really concerned that the anesthesiologist already failed with that, so it might be a problem. We enrolled that. So long story short, we had everyone in there. So this is a real pragmatic trial, really real-world experience.
Yeah.
So that means these are the patients we see on a daily practice, at least in my institution, Cleveland Clinic. And yes, we are implementing that in daily practice. I would hope that we will reach 100% pretty soon. But of course, also in my institution, we have some people who still believe in direct laryngoscopy. But I see the trend is clear. Video laryngoscopy is replacing direct laryngoscopy. I don't have the actual number from this month, but it's clear it's going up. It's really going up.
So there's the practical application of clinicians at the bedside or in the OR utilizing the technology. And I think adoption is coming there. I think many people are getting the message. And technology is advancing so much, and it's in the ORs, but some ORs, it's not there. So, when you talk about like the value proposition of utilizing this equipment, many of us have to go to our hospital administrations if we want this and ask them for that. So what is the value proposition from your point of view, utilizing video laryngoscopy?
We went through the process just a couple of years ago. In our institution, we were purchasing a huge number of video laryngoscopies, and they are now available in every operating.
Oh.
And I think there is one basic question we as physicians, but also hospital, has to ask ourselves. Does it really matter how we practice medicine? And I strongly believe it's evidence-based medicines. We have to do the best for our patients. And the evidence is clear. It's clear. So a video laryngoscopy is superior. So why should I hold on the horse or the direct laryngoscopy, right? So the evidence is clear. And I think in terms of convincing key opinion leaders in the hospital, show them the evidence. It's clear. Yeah. One is better than the other. And it's ultimately the decision. How do you want to practice medicine? And I'm really happy. Cleveland Clinic, we believe in evidence, we believe in science, and we follow the evidence. And that's the reason why we have video laryngoscopes available now.
And tell me, how do you think this study generalizes outside of the context of anesthesia? Because there's obviously intubations going on in the community, paramedics, in the emergency department, in intensive care.
Yeah.
Do you think the same holds?
Yes, so it's not only our trial. Our trial was done in the operating room, but it was a really pragmatic trial. Again, it was not only this super most experienced physicians. We had CRNAs. About 40% of the intubations were done by CRNAs. We had residents, we had fellows, we had a few med students, but we also had staff anesthesiologists. So it's really applicable for everyone working in the operating room. And I strongly believe providers in ICU, they have more or less the same experience like we do in the operating room. But again, it's not the only trial. We have other trials with the same results. Brecker, for example, I think it was New England Journal, published last year or 2 years ago, more or less the same trial in the same setting, but in ICU, coming up with the same results.
Yeah.
So there is no discussion anymore.
It's a slam dunk.
Yes, absolutely.
So it should be the gold standard.
Absolutely. Yeah, absolutely. Yeah. If we were just talking about slam dunk, I believe in LeBron James coming from Cleveland. Absolutely. It's a slam dunk. Video laryngoscopy is superior and should be the gold standard.
There you go. I think that wraps that up very nicely with a little bow on. Kurt, thank you so much for sitting down with us and enlightening conversation. Love always hearing about the evidence and, continuing this conversation to help hopefully impact practice and with our fellow clinicians.
Yeah.
So it's important. So thank you so much.
Thank you very much. Yeah, thank you.
And thank you for listening to TopMedTalk. You can always find us at TopMedTalk.com. We're on all your favorite social media platforms, all your podcasting platforms. All that information is there about previous conversations we've had about video laryngoscopy. So check that out. We wanted to give, before we close, a big shout out to the American Society of Anesthesiologists for supporting us to be here at the meeting this year with this beautiful booth, and to all of our sponsors and all of us who support getting this message across for all of our TopMedTalk listeners. So thanks, everybody. Cheers.
Bye-bye.
Bye.
Cheers.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is epom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. epom.org.